you at a different time? We should do that, just saying.
Yeah, let's
Do that,
Sorry.
it's okay.
And at one point, there's an in-service in October, so the Tuesday group misses out too on a day. So,
Would you prefer us Monday lab people if we want to work with you? Do you want us to like try to group together?
oh yeah, that would be very efficient for me. Yeah.
Okay.
Not just one-on-one. Sorry, I wish I had more time to do that.
About
Well, I need it.
All
Yeah.
right. Patient interaction. Raise of hands. Who has already worked in healthcare? Great. So you've already had some patient interaction experience, right? Good, bad?
Well,
so yeah,
All of the above. Okay, good. All right, we're going to identify some qualities needed to be a caring X-ray tech. Okay. Specific needs that cause people to enter our rooms. Discuss general needs that patients may have according to Maslow's hierarchy of needs, and how differences relate between the needs of the patient and those outpatients, inpatients and outpatients. Right? Everybody knows the difference. No, you're not enough. After this slide. Explain why patient interaction is important, as well as with family and friends. Some of the most negative interactions I've had with a patient is not with the patient, but their family or friend. Analyze effective methods of communicating with patients of various ages. Appropriate interaction techniques for various types of patients. We're going to talk a little bit about considerations of physical changes of aging with regard to X-ray procedures, and discuss appropriate methods of responding to terminally ill patients. Patient's needs. Understand that if a patient has a choice between visiting a nice restaurant and visiting the medical imaging department, what do you think they would choose? I'd 100% go to Pierpont's before I go to North Kansas City, and I love North Kansas City. They are all in altered states of awareness. Not everybody's the same, right? Fear of the unknown is profound. They fear loss of control. Everybody does. Emotions may be unnatural, fearful of possible pain and discomfort, apprehensive about exam results, right? I've had shortness of breath for some unknown reason. I was a very healthy person until 2 weeks ago, and I'm coming in to get a chest x-ray. In my head, I've already built it up that it's a chest tumor, right? That I've got cancer, right? I'm blowing it way out of proportion. Our imaginations are our worst enemy. Emotional intelligence takes self-awareness, self-regulation, motivation, empathy, and social skills. Not everybody in this room will come into this field with the same emotional intelligence. Securing a patient's cooperation is one of the most important and most challenging things that you guys will encounter in your new roles. But there are ways that we can help them to do this, right? To comply and be cooperative. Your personal needs as a technologist. You need to be wanting to help others. I really hope that you do. You like working with people. You cannot hide behind a computer screen all day. Making a difference. Thinking critically. Right? That term, thinking outside the box. You're going to have to do that in certain situations. I guarantee it. Demonstrating creativity. There have been some views that I've had to get on a patient, and I've had to get creative. I've had to prop things up. I've had to utilize a box from the gloves to get the patient in the right position, or the IR in the right position doing a portable. I've had to get real creative in certain situations. Achieving results. Okay? Working with patients requires an understanding of one's emotional intelligence. Like I said, we all come into this room at a different emotional intelligence, and it has nothing to do with your age, your race, your ethnicity, right? years, she would look at you when she was a student. She would barely speak to you. It was so awkward to watch her talk to someone, especially a patient, in the very beginning. And she is a completely different person now. She's probably been a tech less than 8 years. Because I was well into being a tech when she was a student. And she will totally admit now, and she has better interactions with us as her coworkers even, that she has grown, that she can talk to people, she can jump into a conversation out in the main hallway with her coworkers. Before, when she first became a tech, she was like this. She was always reading something or staring at her computer. Like, you would say, "Hey, Malia, how are you doing?" Like, we really did not understand her, but we grew and she grew, and she has really overcome some things as far as her introvert personality traits. So it's important to understand you're walking into when greeting a patient, okay? Understand and have in check your current emotions. You might have just got off the phone with your boyfriend and he really pissed you the F off, and you can't believe it, and this day sucks, and I got nothing in my bank account. But you gotta turn that off and walk in and go, "Hi, Sophia, I'm ready to take your x-ray. Can you follow me back?" Right? So whatever you've got going on, you've got to turn it off. I know that sounds really callous. And if you don't think you can do that, then ask someone else to take over for you. Okay? Your emotions should demonstrate caring and empathy for your patient. Individuals with high emotional intelligence are said to be more successful on and off the job. The patient's needs. You guys know a little bit about Maslow's hierarchy of needs. We've taken a general psych class here. Never knew that I would use both of my degrees so much as I did once I started really interacting with patients. I have a background in psychology as well. Sorry, I didn't tell you guys that before. So, the most basic at the bottom of this pyramid is the physiological, the basics, right? Food, water, shelter. Like I was saying about the homeless patient. If they don't even have some of those things, it's like staying at the Holiday Inn. They might be really sick, but they're in the hospital. They've got what they need finally, right? Safety. You get some patients that home is not safe for them. So when they're into the hospital, they might start to feel safe. Belongingness and love. This is one of the things you have to overcome with some patients that are exploring their gender identity, right? They don't feel belonged or loved, and so they don't seek medical attention. That's one thing that I learned from that lecture. Esteem. The need to know and understand. Some patients really want to know what's going on. Some patients don't. You have to respect that. Aesthetics, and then self-actualization. It's the top of that pyramid.
That pyramid's on page 143.
And it's on this slide as well.
Thank you. On this slide.
People strive from a basic level of physiologic needs towards a level of self-actualization. Okay? Sometimes you can take a little self-check, and go, where am I on this pyramid? Where am I today? What's being met? Right? Some days you may not be feeling like you belong or loved, right? So that's going to hinder you from going up this pyramid. Each level of need must be satisfied before an individual proceeds to the next level. Patients are often at the lower levels of Maslow's hierarchy. This also has to do a lot with how you guys are learning, right? If some of these lower things that you're struggling with, that you're stressed out about, may be barriers for you to really start to process some of the stuff that we're spewing at you when you come in here 3 days straight. Patient dignity deals with the patient's self-esteem. I had a teacher that made us take home a patient gown and properly wear a patient gown with it open to the back and walk around our house in it, and we had to write a paper. made us feel. You're laughing, Emily, but it's true. I mean, it actually was kind of eye-opening. Now, had I been a patient prior to that? Yes. Had I been in a situation prior to that where I had given birth already, so I didn't care, right? So, but some of my classmates had never been a patient, right? Never put on a hospital gown before. So it was kind of eye-opening. That's just one way that you can help a patient's self-esteem, is making sure that their behind is covered, okay? Patients feel a strong loss of power over their fate, especially when they're exposed. Embarrassing situations that they feel isolated from others. Loss of privacy and access to loved ones. This was a big thing during COVID, right? These patients were isolated in rooms. Their loved ones couldn't come up and see them, right? The only person they were seeing was myself, a nurse, a phlebotomist coming in, and we're all gowned head to toe, right? Feelings of guilt on several fronts, referencing them in an impersonal slang fashion, right? They discourage you from using any slang. Don't say bro to your patient, please. Initial patient interaction. You do a patient assessment when you're looking at a patient, right? If my patient's hobbling in like this, right? I'm gonna say, okay, maybe they hurt themselves, maybe it's their hip, maybe they got back problems. They may be coming in for a chest x-ray, but I just did a visual assessment of my patient, okay? Use their name and ask preferred name. Confirm their identity. This is very important. You do not want to x-ray on my patient. Can't stress that enough. Introduce yourself. Smile. And not like a crazy smile, but smile, if you smile with your eyes, right? Right? Explain the procedure in terms they can understand. Alright? Practice this, guys. Like, think if you were talking to your grandma or your grandpa or somebody that may be really nervous to go into a medical situation. Think about how you're going to say it to them to make them understand in layman's terms. Okay? Obtain a brief and relevant history. Notice that's highlighted. Relevant. Come in for a chest x-ray and they're telling you everything about their bum knee. Okay? Obtain informed consent if it's required. A lot of times this is for a needle procedure. You're going to have to get consent for it. A patient's family friends should be viewed as an extension of the patient in terms of communication methods. On page 145, figure 11.3. This is a really good picture. You see the technologist talking to the patient in the wheelchair. The family members are not sitting back in their chairs, they're leaning forward. They're wanting to hear the conversation, okay? You may have grandma sitting in the wheelchair, but the daughter and son-in-law sitting in the chairs are caregivers. They know a lot about grandma because she lives with them, right? Sometimes they can be a wealth of knowledge, okay? They can also sometimes get in your way, so be courteous. Sometimes they'll want to help you get grandma up. They'll follow you into the x-ray room. Politely ask them to step out, right? But know that they are an extension, that they are also just as concerned for that patient as the patient is concerned about their own health. Know your patient, whether they're an inpatient or outpatient. You guys have an opinion on who you think is easier? You would think that an outpatient is easier, but not always, right? Look at the orders, the chart, find out as much as possible about the patient as you can. This is prepping you to be aware and ready for your patient, right? If there is a little special note that you've got an outpatient and they are 350 pounds not weight bearing, and you're having to bring them back for a chest x-ray, and oh, by the way, you've got to use the Hoyer lift to get them out of their motorized wheelchair. That outpatient now has become way more complicated than you expected. Okay? But your educating yourself about your patient before you go out to get them, so you can do a better job of taking care of them, right? The rad tech has a responsibility to make patients as well as their family and friends feel confident that you are giving that patient the best care possible. And just to define, an inpatient is someone who has been admitted to the hospital or for diagnostic studies or treatment and can stay for up to 24 hours or longer. A lot of times these inpatients go up and down the Maslow's hierarchy of needs, right, during their stay. And something that they've maybe experienced at another facility or another hospital stay at the same facility may shape their experience. So be very aware of that. And it can shape their attitude and how you walk in and do portable chest, and they had the worst portable chest of their life the last time they were in the hospital. And so they're thinking about that experience. They're not thinking about the experience you're going to give them, right? An outpatient is someone who has come to the hospital or outpatient center for diagnostic testing and treatment. It's not usually stay overnight. Now, doesn't mean an outpatient doesn't become an inpatient for some reason. Often arrives in radiology with a preconceived expectation. I'm going to get in, I'm going to get out. I'm going to come in, it's a simple chest x-ray, and they're going to let me go. This is not going to take more than 15 minutes. Right? Usually have outside schedules and other commitments. Expect to be cared for on time according to the scheduled appointment time, and that's it. So that's another constraint with an outpatient. Right? You come in last minute, you're a walk-in chest, but everybody and their brother in Kansas City has decided to come in and get their x-rays the same day you did to the same facility, and we're behind. And Miriam called in late. So now you're down a tech too. You get Karen walk in, and she's like, I'm gonna get my chest x-ray in 15 minutes or less. Right? Well, Karen's gotta wait 45 minutes, and she is not happy about it, and her kids are getting off the bus, and she needs to get home right now, right? So she's already got all that going on before you ever walk her back to get her chest x-ray, right? So these are all considerations you gotta take into play when dealing with an inpatient versus an outpatient. Between you and me, I'd rather do an inpatient every time. So that's the breakdown of this slide. Sorry, I already said it. Communication is critical to the likelihood of the success of the exam. Communication and patient safety go hand in hand, right? If a patient understands what you're asking them to do, they should be safe. Okay? I don't know how many times I've had a patient, the transporter, I can overhear the transporter bringing them in. They're in a wheelchair. The transporter locks the wheelchair, says, okay, don't get up. The x-ray tech will be right in. I walk in the room and the patient's already standing out of the wheelchair. They did not listen, or something about the way that the transporter had explained to them not to stand up out of the wheelchair just did not cross over. Okay? Effective communication is essential at all levels in healthcare delivery system, whether it's written, oral, or electronic. Some essentials to communication. Patient care communication must be patient focused, right? Always patient focused. It needs to be accurate and timely. Don't go too in depth with your instructions and stuff. I've kind of brought that up in lab, right? Being concise, clear and concise. Always remember to consider communication and related to a patient's family and visitors, right? Especially with kiddos. You get a preschool age kid, say 4-year-old, has no stranger danger, will walk right back with you to the x-ray room. The mom is following close behind. Mom is anxious, right? So be considerate of that, and just politely tell her, "We're good. I'll come get you. You can stay right out here in the hallway, right? Safety reasons, you can't be in the room with little Timmy." As a technologist, communicate within your scope of practice. This is very important to understand what your scope of practice is. Do not give any diagnosis, right? Now, you get a patient come up, you're standing say, yeah, that's their heart. It's really big. They have cardiomegaly. Nope, pretty sure I'm not an MD, right? But I can point things out. I get patients who want to see their x-rays all the time, especially after they've had surgery, like a back surgery. Like, well, he's saying something about he put a cage in my back. And I can take them back to the screen. I can show, well, here's the hardware that Dr. Righteous just put in your back 2 days ago, right? Looks like it's levels T1 through T5, right? Because I can count those things. I can point it out. Now, if it's properly placed, because you'll get a patient go, well, does it look good? And I say, I'm not a doctor. That's a good question to go over with Dr. Righteous when you see him, right? Because he'll review your images. So know your scope of practice. Verbal skills. You should speak face to face with the patient when possible. Right? Don't turn your back and start giving them instructions. You'll get really good at walking backwards as you're stepping back to the control panel. All right, take a big deep breath. Hold that breath. Right? You want to always keep eyes on your patient. Speak at the appropriate level that your patient can hear. I don't know how many times I feel like I've just yelled at a patient and everybody out in the hallway can hear me, but that's where the patient's at. They can hear me at that level. Use humor if appropriate, and please use appropriate humor. No dirty jokes. Do not tell it. You can hear a dirty joke. The patient will tell you a dirty joke. I promise you. But use appropriate humor. Communication is key. There is nonverbal skills. Paralanguage is the music of language. It is often considered a nonverbal form of communication. Note that is a highlighted term. Patient receives signals about your attitude toward them through your voice. I came up and said, okay, Miriam, let's go do a chest x-ray. What's that say to you? What do you think? Am I ready and happy to do a chest x-ray on you? No. Body language. I've said it in lab, I'll say it again. You will have to touch other people in appropriate manner. But you will have to touch your patient, okay? Emotional support can be given. If I walk up and I go, okay, Miriam, I understand that you're very upset. We're gonna need to get your chest x-ray. Okay? Or just putting a hand on a shoulder when a patient's telling you something. The patient breaks into tears, right? You can touch them, right? It gives them support emotionally. Touching for empathy, touching for palpation. I think I did this in all 4 labs. Did I go around and show you like appropriate like pressure and touch? Okay, everybody remember that? See a few non-head shakes, but nonverbal skills. You say a lot about you as a technologist when you walk in, right? If you're wrinkled and disheveled and your hair is greasy and not clean, if you have a smell about you, that is a nonverbal communication to your patient about you. Okay, so maintain a professional appearance. Please have personal hygiene. How you stand and talk is your physical presence and visual content. Okay. A little bit about touch. These first 2 pictures are appropriate palpation of the crest. This is also in your book, by the way. So you can use 1 finger, 2 fingers, 3 fingers, but do not lay your hand flat on somebody's hip like this. Okay? That is not appropriate. It says before touching a patient, his or her permission to do so should be obtained. Touching without consent can have legal ramifications. Okay? Some people don't want to be touched, but you need to make them aware that you're going to touch them. That you have to. And I had a good question, I can't remember who asked it. Somebody said, what if my patient really doesn't want to be touched? Well, you can always demonstrate, right, how they need to be up at the board, how you need them to do things. That is totally understandable. But you will probably have to help them or touch them at some point, get to that position. 80% of people age 65 or older at the 5th grade level. It was an interesting fact. I thought 48 to 80% of patients age 60 and older have inadequate functional health literacy. You guys know what that means?
They don't know what's going on.
Right, they don't know like basic health terms and things, okay? They really can go into a medical situation and be quite overwhelmed and scared. Understanding your patient's common patient types, whether they're seriously ill or they're a traumatized patient. Cancer patients tend to have gone through a lot of stuff before this point. COVID patients can be very seriously ill or have been traumatized from the prior COVID symptoms, right? They're really isolated. They're visually impaired. Both my grandparents had macular degeneration on my mom's side. My mom has the potential to have it. I try to have really good eye health myself. But my grandmother had like tunnel vision. She could see a lot of shadows and things. She lived to be 95, but as she got older, it got worse. So it was very scary for her, right? She had to know where things were in her house. Speech and hearing impaired, right? Somebody might have a really bad stutter, and it's really hard for them to get out exactly what they're trying to tell you about their medical history. So just be patient, right? Non-English speaking. This is a big one. Really heavy accents, right? Try to understand what they're saying. Have them slow down, whatever you need to understand them. Mentally impaired, okay? You don't know what's going on in somebody's head when they come in. You don't know what they've been through. So just try to be empathetic and kind. Substance abusers, right? We talk about this for half a lecture, but just know that substance abusers might be coming down off of something, right? Maybe they're detoxing, which will change that hierarchy really quickly, right? They're very scared. They don't feel like they belong because they don't know where they're fitting in anymore, right? So just be aware. Again, you can go back to the patient's chart. Maybe you saw something in their chart saying, patient here for detox. Okay, I might know that this might need a little bit different approach, right? Mobile and surgical patient communication. These unique patient care environments require special patient communication considerations. Somebody said when someone is out that they can't hear you. I had a teacher tell me, be careful what you're talking about in a patient's room that is sedated and intubated, because you just never know what they're going to hear and remember. I've heard stories of patients saying, oh yeah, I remember the surgeon talking about that while I was under getting surgery. So be very aware, okay? Under no circumstances should you assume that the patient does not comprehend you within earshot, right? So you say you have the worst patient in the world and they are limited English speaking, and you walk out into the main hallway and you go, oh my gosh, I wish they would just speak English, right? The patient can still hear you. You may not think they can hear you, but also be careful of crosstalk in the hallway and stuff when you're talking to technologists, because you might be talking about a completely different patient, but the patient thinks they're talking about you. I had that happen. We had a lady staying in the same room for about an hour or so doing a small bowel follow-through. Those tests can take a while. She'd been sitting in there, you know, isolated, alone. She was already not feeling great. We made her drink this nasty stuff, right? So she's pretty low on the Maslow's hierarchy of needs. And then she hears us laughing and joking about something else out in the hallway, and she thinks we're making fun of her. We were not talking about her at all, but she could overhear everything we were saying, so be very careful. And always please consider the patient's family and friends, like I said. I had an incident, we had to call security. It was a pretty bad break in the knee in the ER. The lady was obviously very concerned for this loved one. I don't know their relationship, but she accused us of intentionally hurting this lady when we were just trying to get the best images possible. Me and another tech were doing it, and she followed us out of the room and down the hallway and got in my coworker's face and said, "You did that on purpose. You were hurting her on purpose." We had to, thank God we had cameras because they had pulled the tape. And we had asked her to leave. She kept coming back in the room. She was not listening, right? And the lady was already screaming, and I understood it hurt because we could see that it was broken, right? But we're not moving her leg. We're not having her bend it up. We were doing all the appropriate things. But the family members may have a different perspective. So just know that you need to handle them sometimes with what I call kid gloves, right? Showing empathy is a very powerful tool when dealing with patients, families, and friends. So just keep that in mind. If you feel threatened, if you feel like the patient's family member is using harsh words, cussing, getting in your face, do not hesitate to tell somebody to call security, because you do not deserve to be treated that way. Patients should never cuss at you, hit you, right? Despite what they're going through in the hospital. Oh yeah, for CNAs, especially in the nursing homes. Yeah. I don't know how many times my husband's been assaulted as an LPN. So, yeah. So just know that there are things in place at your facilities that if you feel that way, that you have rights to, okay?
So you said that you can call security for either a violent patient or a patient's like
Verbally abusive. They're verbally assaulting you.
the patient itself or their
Patient self too. Because you don't know, like I said, like I've had some patients that are detoxing and they aren't really aware of what they're saying. And they've called me the C word. They, oh, you don't effing care about me.
like can escalate. They can
It can
potentially hurt
escalate.
themselves or
Yes.
someone else.
So call security if you feel like the patient is not being respectful. Okay? Also, you will get patients that don't want to leave their loved ones, so just explain that it's not safe. They are not the patient, because you'll get, wife in the bed, you're x-raying her for portable, you get the husband, I don't care. I'm 70 years old, I can sit in here. No, sir, you don't need the exposure, right? Just explain to them they have to leave the room. Age is a communication factor. Patient age must be factored in communication techniques, right? You're not going to talk to someone that's over the age of 70 the same way you're going to talk to a preschool age person, right? Age is not a barrier to effective communication, right? You've got to figure out how to communicate on all levels. And have those strategies to be used to accommodate age-related challenges. Okay? Little kiddos tend to be more scared. I think I brought this up in one of the labs. Some kids are scared of the dark. It's very dimly lit in X-ray. Turn the lights up a little bit. Okay? How old is your patient? Are they pediatric or the geriatric or the middle-aged? You guys know the age groups? I thought I did. I thought an infant was past 1, right? It's not. Toddlers are 1 to 3, and then you got preschool age. It's kind of scary to think that an adolescent starts at age 10, right? What are you going to ask an adolescent female patient? When was their last period, right? Because you can get kids starting as early as 9 years old. Right? It's scary to think, trust me, it's scary to think that they can even be sexually active that young. Okay? Young adults is 25 to 45. Most of us in this room are young adults. Thank God I'm still in this category. Pretty close to that middle age group. Lord help me. And then I like the term mature adults over the age of 65. Okay? You're going to get a lot of mature adults. Doesn't mean that they're mature acting, but you're going to get a lot of mature adults, okay, as your patients. Pediatric patients, come down to their eye level to talk. Speak softly and with less authority. Set up equipment before the child enters the exam room. This will help you immensely, okay? Go dark. Avoid loud and dramatic equipment movements. Sometimes your old equipment makes a lot of noise. Use gentle touch. Try to maintain eye contact with them. Use radiation protective methods and show them being used to family members. So you got mom holding on to the kiddo. It's got a cool rainbow pattern. Maybe say, oh, look at mom's cool apron. She's got rainbows all over it, right? Keep talking to kids. And remember to image gently. This was a campaign. They use it especially in CT scans to adjust techniques for kid-appropriate sizes. Gerontology. This is age group is expected to rise in the numbers for many years to come. People are living longer, right? I told you a little bit about my grandpa, 101. Yeah, that man had gone through heart issues, he couldn't hear, he lived through World War II, took a bullet through his helmet, went through the back and hit somebody behind him. Like he lived through a lot of stuff. 101 years. The term is geriatrics. It's to refer to older patients, and sometimes it's being viewed as being inappropriate. Terms such as senior citizens or golden agers are considered unprofessional. There's also this thing of like baby talking older patients. You heard about that?
Is that a form of, that's ageism, right?
That is part of ageism, yeah. Treat these patients just like any other patient, regardless of age, with patience and respect. It may take them a little longer to get out of that wheelchair and get into position, right? Remember those challenges, hearing loss, visual loss, right? The aging process itself is not divided into primary aging and secondary aging. Is now, divided into primary and secondary aging. Physical changes of functional aging. They have slower psychomotor responses, so that connection, you say, can you please stand up out of the wheelchair? It may take them a couple extra beats, right? To hear that command and do it. Slowing of information processing. It just takes a little longer for them to, you just went through your whole spiel about how we're going to stand up here, we're going to put your chest up there, you're going to roll your shoulders forward, I'm going to take a picture, then we're going to go like this, right? The faster you speak and the more information you get, then it may not all process through. Like I said, visual acuity decreases. Other decreases in your senses, right? Especially when you get up into the 80s and the 90s. I've had some 90-year-olds that move better than some of my 40-year-old patients, but you just never know, right? Respiratory system, decreased cough reflex. They breathe shallower. There could be a decreased pulmonary capacity. Maybe they can't take that big deep breath. And then kyphosis. We've talked a little bit about kyphosis. Talk about Granny that walks in and she's bent in a C shape, right? Like this. Are you going to get a chest X-ray on this? Okay. Some other things to take into consideration of the musculoskeletal system. They might have osteoporosis, arthritis. They're definitely not as strong. And they have atrophy of the muscle mass. And they're very scared to fall, right? If they've come in and they've had multiple falls, compression fractures of their back because they have osteoporosis, they may really not want to get out of that wheelchair. Okay? Some cardiovascular things to keep in mind. They may be not having the cardiac output that they should due to pathology, right, at an advanced age. They might have orthostatic hypertension. So if they stand up or sit down too fast, they might get dizzy, right? Arteriosclerosis, sorry, I was tongue-tied in that one, is hardening of the arteries, right? Build up plaque and stuff. They might have DVTs, which causes swelling in their legs. Deep vein thrombosis, what DVT stands for. And they might just generally feel tired, just don't have as much energy as they did when they were in their 20s, 30s, and 40s. The integumentary system, touch sensation. So you're having them hold the bar up there, they can't really feel it maybe in their right hand. They may have diminished sensations of heat or cold. And then they generally tend to be colder because they don't have as much fat, subcutaneous fat layer. So you might get a patient that just wants to continually be covered up to here, and you just have to tell them, well, I have to lower the blanket just for a minute so I can get you into position for a chest x-ray, right? But be kind. Offer to go get them a warm blanket afterwards. If you've uncovered them completely to get to a hip x-ray, say, we're going to get you all comfy back in the bed after these x-rays. We'll get you lots of warm blankets, right? Especially if they're already complaining about being cold. The GI system, they may not be eating as much. They may not be able to have those secretions to help break down the food. Their GI tract may not be moving. That GI motility may not be moving, which means they may have some constipation, right? And they may have less muscle control of their sphincter, especially the very last sphincter, okay? You might have a little accident when you stand them up out of the wheelchair. Interaction with older patients. Again, make eye contact, right? I tend to do some of the same things that I do with pediatric patients. If they come into my room, they're sitting in a wheelchair, I may sit my butt on the end of the table and talk to them. You know, make sure that they're seen and they can hear me. Give them a lot of eye contact. Try to speak clearly and a little slower. You don't have to make it this slow, right? But don't be spewing off all the things that you need to do or ask them question after question after question without letting them respond, right? Keep them warm if needed. And ask permission to touch. Say, I'm going to help you get out of the wheelchair. Can I take your arm? Right? Demonstrate compassion. Ask them if there's anything they need to make them comfortable, right? You're going to get, like I said, a lot of patients scared of falling, okay? Well, I can stand up there for a few minutes, but I need something to hold on to. Oh, I've got bars right here for you to hold on to. If you feel more comfortable, if you're really worried about falling, we can do this in the wheelchair, right? Try to be accommodating. Explain thoroughly and keep them informed, right? Again, any patient, if they're an informed patient, they're going to feel safer, right? They're going to be more compliant. Treat them with respect and patience. Try not to rush them. We're going to talk a little about terminally ill patients. Anyone in here lost a loved one to a terminal illness? Did it take them a while? Yeah. It can be kind of a process, right?
Yes, ma'am.
Understand that death is part of the life cycle. Okay? You guys are going to see death. I'd like to sugarcoat this for you, but you're going to see it. Imaging science professionals often deal with the dying process as part of the acute death events. You might have a patient code on you in your x-ray room. Scary thought, but you got to be aware of it, right? And don't tell me that this only happens in the hospital, because it happens at outpatient x-ray clinics too. Okay. Radiation oncology staff deal with terminally ill patients, those rad therapists, right? They see it every day. I think that it takes a special person to be a rad therapist, because you know that the treatments that you're doing for this patient may not save them, right? It may only just be prolonging their life. Society's attitudes toward death and dying have changed to become more open and respectful of the terminal patient's wishes and rights, right? Look for those DNR bracelets. Do not be jumping on a patient's chest if they got a DNR bracelet on. That's a big no-no. Dying patients and their families and loved ones need to work through the grieving process in a natural and individualized time frame. Everybody grieves different and at different rates, right? Some things to keep in mind when dealing with terminal patients. Patient autonomy is highly valued, right? You'll get patients that are going through this, and they may not have advanced directive, they may not have a living will, they may not have a power of attorney, terms are: living will, durable power of attorney. Yeah. So, if you don't know, you should know. And then if you have parents still living, or say you take care of grandma or grandpa, you might be their durable power of attorney. Right? Know the laws too in your state. If I have things in place that I want to happen in the event that I'm no longer with us, I can't allow, there are rules and laws, as long as I've got it in writing legally, that my sister from out of state can't come in and go, well, Roseanne would never want to be an orphan daughter. But my husband knows that I do, and my daughters know that I do, right? So know the state laws as well. The 5 stages of grieving process is denial, anger, bargaining, depression, preparatory depression, and then acceptance. Preparatory depression comes with realization of the inevitable death of the loved one. Is it accompanied by a desire for death as a release from suffering? The most important thing at this time is to permit the behavior. Okay? So, just to kind of touch on a few things, communication skills are essential to good medical imaging, right? A good communication process is a closed loop. Communication strategies used to accommodate the uniqueness of each patient. Meet the patient where they're at. Patients enter the healthcare setting feeling vulnerable and outside their comfort zones. Keep that in mind. Aging and terminal patients present their own set of patient care challenges. What are some of those? So again, just to kind of reinforce and kind of highlight some things that I think are important for you guys, I'm going to come next Monday again with a pop quiz like I did, just a little warrior knowledge, right? Kind of brush the cobwebs off in there.
You don't have class
Sorry, 2
next
weeks,
Monday.
yes, that's right, gosh. Does not seem possible that Labor Day is this week. Not that I'll really, you know, because I'm probably working on school stuff, but the point is that 2 weeks, when we come back on a Monday, we'll have a little pop quiz. Probably not an actual quiz on campus for 10 and 11, but just know that that'll be there. Yes?
I just wanted to add, when you were talking about knowing the laws in your state, it reminded me of an essay that I did for my English class, the Death with Dignity.